Ladies and gentlemen, thank you very much for attending the APASL 2024, the Center of Hepatology. Now we would like to start our conference program. Now we start the first session, ACLF1, Recent Changes of Incidence and Etiology of Acute Liver Failure in Asia-Pacific region. Moderators, please.
Good morning, everybody. How are you today? On behalf of the moderators, I'm Yasuhiro Asahina from Tokyo Medical and Dental University. It's a great honor to moderate this distinguished session entitled Recent Changes of Incidence and Etiology of Acute Liver Failure in Asian Pacific region. So today we invite three distinguished speakers. So please discuss actively, okay? So first presenter is Dr. Yasunari Nakamoto from Fukui, Japan. So please start, Dr. Nakamoto.
Thank you, Chairman, and thank you for Professor President Shina for providing me an opportunity to present the data here. So today I'm going to talk about the development of novel hepatitis B therapy with antiviral host factors induced by acquired immune responses. There are no COI. Acute on chronic liver failure, ACLF, is a complex syndrome defined by existence of different organ failures in patients with chronic liver disease, mainly cirrhosis. The patients who develop ACLF present a hyperactive immune system, profound hemodynamic disturbances, and several metabolic alterations that finally leads to organ dysfunction. These disturbances are triggered by different factors such as bacterial infections, alcoholic hepatitis, gastrointestinal bleeding, or hepatitis B virus flare. So in this recent paper, the clinical causes of HBV-related ACLF failure are discussed and presented a multi-state model to predict disease evolution. So in this study, 3,990 patients were enrolled, and of them, 1,736 HPV-related cirrhotic patients were included, and 137 developed ACLF within 28 days. Also 308 ACLF at enrollment. And finally, 70 patients with ACLF progression and 195 with ACLF stabilization, and 8 with ACLF improvement, and 166 with ACLF remission. So we learned very high proportions of patients are due to HBV chronic infection. These factors for the mortality of HBV-associated ACLF were discussed in this paper in systemic review and in meta-analysis. So the most significant risk factors for HBV ACLF mortality comprise hepatorenal syndrome, and hepatic encephalopathy and HE grade, and followed by the INR and hyponatremia, and other monocyte cirrhosis and SBP have been confirmed as additional key factor for HBV associated ACLF mortality. So regarding HBV, currently it is very tough to eliminate the virus. So in this article in Science, and Dr. Sue Wan, a physician at St. Bernard's Medical Center in Livingston, New Jersey, and she is chronically infected with HPV herself. And her husband received the vaccine, as did her 4 children, who are also infused with HPV immunoglobulin. And eventually, no family members are infected with HPV. So we learned from her family that currently HPV infection is protected by HPV vaccine, also immunoglobulin. However, once infected chronically, the elimination is very difficult. So in this paper in Nature, the finding that Viking carried smallpox viruses shows how genetic is changing our knowledge of past disease. So in this paper, hepatitis B had been infected humans since the Bronze Age, 5,000 years ago. And this finding are shaking up researchers' understanding of how disease have affected human population throughout history. In another paper in Nature, the ancient HPV virus from the Bronze Age to the medieval period, the root of the HPV tree is projected to be between 8.6 and 20.9 thousand years ago. That's the Bronze Age. So we have a very long relation with hepatitis B virus, and still we have no tool to eliminate the virus. And the hepatitis B is increasing. The death of the world death due to the hepatitis B virus is increasing, but there are coming up probably more than malaria or tuberculosis or HIV. And most of the patients exist in Africa and Asia. So the problem is universal vaccination are not functioning very well in mainly in Africa or in the world. So just 10% patients were diagnosed. Well, however, other 90% patients were precisely diagnosed, so they can be infected mother to provide the virus to the infant. So in this article, hepatitis is now kills more people worldwide than HIV, tuberculosis, or malaria. Tackling the hepatitis virus in Africa is key to fighting back. So many researchers are trying to hit the virus where it lives. In a push to cure hepatitis B, the drug developments are targeting nearly every step in the virus complex life cycle. You can see life cycle here. And they are also trying to boost the immune response. And they believe a curative drug will have to eliminate covalently closed circular DNA, cccDNA, and the cccDNA can remain latent for years and can adopt a highly active open form that churns out new viruses. So in the previous study, we learned two immunological conditions of hepatitis B, virus and carcinogenesis. When we inject HBV-specific T lymphocyte, this is a cytotoxic T lymphocyte, CD8 positive CTL, injected into HBV transgenic mice. The T cells are activated to produce interferon gamma, and that non-hepatotoxically inhibits the viral expression and propagation. So we learned this is a non-hepatotoxic antiviral effect. And also, at the same time, the CTL induced a hepatotoxic agent to cause chronic hepatitis from day 7 to 18 months to cause hepatocellular carcinoma. So we call hepatotoxic inflammatory carcinogenesis. And in this review, the compound interfering with cccDNA formation is for the prevention of cccDNA amplification and infection of new cells. And these cytokines and molecules are good for functional cure of infected cells. And interferon alpha or interferon gamma are supposed to be helpful to complete cure of infected cells. So based on these results, we more focused on this effect, interferons and cccDNA. The other many trials are developing in the world. For example, attachment inhibitor, entry inhibitor, internalization inhibitors, or oligomerization inhibitor, a small molecule fusion inhibitor, or segregation inhibitor too. And this is our aim of our study. Using in vitro HBV infection systems, a novel antiviral host factors that regulate the cccDNA and the molecular mechanisms were investigated by gene knockdown methods and functional gene expression analysis. And this is the HBV plasmid used in this study, and this is provided from the GT Medical University and Professor Okamoto's group. The genome, we use 1.3 length HBV viral genome. They have the BCP point mutation, also a prequel mutation of the genotype C2. And so they induce a very high transcription virus production. So using this plasmid, we transiently transfected the plasmid into hep D2 cell. And this hep D2 cell produce hepatitis B virus particle in the supernatant. And this viral particles were used to infect in primary human hepatocyte PXB cells. In other method, this transiently transfected cell were selected by the neomycin to establish a stable HPV clone, HPV transfected clones. We call HepD2D11 cells. And HPS antigen and the viral DNA, RNA, and cccDNA were mainly detected by the real-time PCR method. So we know intracellular signaling pathway of interferon gamma include or consist of the antiviral molecule STAT1. So to analyze with this intracellular pathway, we knock down the STAT1 using the siRNA in HepG211 cells, and this is a stable transfectant of HBV clones and virus genome. So we can see knockdown of STAT1 and also the suppression of STAT1 function. This procedure caused HBs antigen production and in the absence or presence of interferon gamma. And also we can see the increase of HBV DNA and intracellular DNA production. And in contrast, in knockdown of STAT1 in the absence or presence of interferon gamma, in an in vitro infection system of a primary human hepatocyte, PXB cell, they cause suppression of production HBs antigen. And DNA, also intracellular DNA, RNA, and cccDNA after the infection. So to analyze the mechanism, we performed the microarray analysis in those cell lines. And an RNA microarray in PXB cells shows the 24 gene sets were induced, and of them, 21 were metabolism-related pathway. Well, in contrast, STAT1 knockdown in HepD2 cell induced much less gene set change. And also knockdown of STAT1 in PXB cells. No, I'm sorry, this is not the STAT1. This is IRF2. IRF2 is another known anti-HBV molecule. IRF2 knockdown causes much less gene change. So we focused this pathway and the antiviral effects in the next experiment. If we compare the the microarray analysis of PXB cells, also HepD2 cells. And we detected the 43 genes were induced in PXB cells. However, we cannot see them in HepD2D11 cell. And these are 23 genes were down or suppressed in PXB cells and not in the HepD211 cell. So we established a siRNA library of that 43 genes and analyzed in this HBV transfectant. So if we transfect the siRNA of these genes, we can see the red bar 12 genes were caused the HBs antigen increase, the showing the antiviral effect. And in addition, we performed the double knockdown of STAT1 and these indicated genes. And so again, we see this molecule FH and NMT shows a high antiviral effect. And also this in cccDNA too. So in this experiment, siRNA knockdown treatment of FH and NMT molecules were performed, and HBs antigen were increased. Also, DNA and intracellular DNA RNA were increased using this siRNA FH. So that indicates that FH shows the antiviral effect against the hepatitis B virus. And FH is a humarine acetoacetic hydrase. And this molecule is included in the tyrosine metabolism pathway here. And hereditary deficiency of FH is known to genetic hereditary tyrosinemia type 1. And in that patients, we can see liver injury and carcinogenesis. And so in this experiment, we established FAH cDNA full-length plasmid to transfect HepD211 cell. So after the transfection of FH molecule, we can see this elevated expression of FH, and that causes suppression of HBs and DNA, especially in the intracellular DNA, RNA. So, collectively, elevated FH gene expression in hepatocyte may inhibit HBV replication. And in addition, we know humarate. This is a downstream of FH in this tyrosine metabolic pathway. And also, dimethyl humarate, DMF, is known as approved drug, Tacfidera. Tacfidera is a multiple sclerosis treatment. But so this we put this drug into the culture cell. So we can see a suppression of HBS, DNA, and intracellular DNA, RNA. Also, there are activation of antiviral intracellular molecules and oxidative stress. So I think this is a hopeful molecule to establish the new HBV anti-HBV drug treatment. So finally, we identified a molecule, antiviral host factor FH, that suppresses HBV replication using the in vitro HBV infection assay systems in primary human hepatocyte. And the undefined host factor was found to contribute to the control of viral infection independently of STAT1 by comprehensive functional screening. And finally, I appreciate the study performed in the University of Fukui, and I appreciate the initiation of HBV study in the Scripps Research Institute, also at Kansai University, and then HBV plasmid from GT Medical University, Professor Okamoto's group. Thank you for your attention.
Thank you. Thank you, Dr. Nakamoto. He comprehensively explained the importance of HBV in the ACLF field, and also he present antiviral new molecule that suppress HBV for future therapy. So now this paper is open to discussion. So any comment or question from the floor? No. So, so you identified the new molecule and the host factor FAH. So your knockdown system clearly showed the suppression of the HBV. So how is the experimentation of the overexpression of the FAH? How is the, do you check the overexpression model?
Yes. No, only data we have is the FH, the cDNA transfectant inhibit hepatitis B virus expression. So probably FH is a very rich molecule in the liver. So the probably next problem is how do we deliver and specifically expression in liver.
So this is a host factor. So are there any SNP or the host another genetic factor to regulate this molecule?
Yes, that is as I showed in the slide. That is the hereditary genetic mutation caused that kind of tyrosinemia and to cause a liver injury and liver cancer. So what we are thinking is that this molecule have the antiviral effect and also functioning to suppress the carcinogenesis because the deficiency of FH caused the liver injury and liver cancer. So if we put FH molecule into the liver, that may suppress HBV and also hepatocarcinogenesis.
And you, regarding that, you mentioned about the mice model get HCC in the liver. Do you check this molecule to suppress the hepatocarcinogenesis in that mice model?
That's right. We checked the FH expression in that model. That was suppressed in the HCC. Also, we have the data in collaboration with Nishida in NCGM. So he has the data of the FH molecule is suppressed in the HCC patient, especially the HCC tissue compared to the background liver. So we believe that may work for anti-HPV and also anti-cancer new candidate.
All right. So that's why the discrepancy between the HepG2 model and the PXB model.
Yes.
Okay. Any other questions? I think that Dr. Ibinuma.
Thank you for your beautiful talk. I have one question. This FH suppression is specific for HBV? How about the other virus?
Yeah, it's a good question. But so far, in the literature search, there are no effect were shown. No effect, no antiviral effect were shown in that paper. So, so far, there are no antiviral effect report.
Thank you very much.
Okay, and it's very promising. You did have the patent this molecule for the treatment for HBV. Are there any future schedule or roadmap to this molecule to introduce a clinical practice? Do you have any plan?
Yes, we are just we don't know. So far, we are trying to make this molecule to close to the more clinical application, but we have more. Probably we have to do more experiment to using other animal.
Okay, thank you. Any question? Nothing? All right. Thank you.
Thank you.
Dr. Nakamura. So I transfer the microphone to the moderator. Oh, this is here. This is right. Okay. I transfer the microphone to the moderator, Dr. Ibinuma.
Next speaker is Dr. Nakayama. He's speaking about the recent change of incidence of and epidemiology of acute liver failure in Asia Pacific region. Please talk your presentation.
Dear Chairman, thank you very much for a kind introduction. Today, dear all participants, let me thank to the organizing committee of this meeting for giving me the opportunity to talk in this session. Today, I will talk about recent changes of incidence and etiology of acute liver failure in Asia. In the first part, I'll talk about etiology of countries in Asia Pacific regions. And in the second half, I will talk about the recent status of ACLF in Japan. I have nothing to declare for this study. This is the report, a single center study from India. In India, HEV and antituberculosis therapy, ATT, is common causes of ALF. And this table shows the clinical background of these patients, and this slide shows that ALF with HEV has relatively better prognosis comparing other ALF. And this slide shows several reports from Indian centers. And these reports indicate that the frequency, there is variations in frequency of ALF due to HAV and HEV. And this is reports from China, a total of 177 cases in 7 hospitals. So in China, traditional Chinese medicine is the main etiology of ALF. And in Thailand, the most frequent causes of ALF were indeterminate. This is the big data. So the patient more than 20,000 to 20,000, and patient ALF patient hospitalized between these years. In Australia, paracetamol was the most common etiology of acute liver failure, like European countries. So almost 5% of cases. And comparing with the old data, the paracetamol ALF due to paracetamol is increasing. On the other hand, ALF due to indeterminate is decreasing. This is the reports from single center study from Korea. In the past, ALF due to HBV is the most common etiology in Korea. But nowadays, this is the recent etiologies of ALF in Korea, and HAV infection is most common etiology in Korea. So this is the current status of HAV hepatitis E in Korea, the number of annual reports cases. So after 2009, HAV hepatitis is prevalent in Korea. So this is a proportion of etiology of recent acute viral hepatitis in South Korea. And you see that almost 80% of viral hepatitis is due to HAV infection. So let's think about this reason. The causes of large outbreak acute viral hepatitis A in Korea. The one thing is that the immunity level of hepatitis A in adult is getting lower. So the seroprevalence of HA antibodies in adult decreasing year by year. But on the other hand, the hepatitis A IgG seropositivity rate in group aged 0 to 9 years has been increasing because they started national immunization program to the young people. And the second cause for the large outbreak acute viral hepatitis A, this is Korean dietary culture. Salted clams are traditional Korean food. However, recently salted clams are imported, and this contains a large amount of HAV. So These maybe this and this is the identified at risk factor during the 2009 outbreak. This is a report of hepatitis A in Korea from 2011 to 2009. And they have, in 2019, a large outbreak. And this is the male and female, the proportion of male and female and age distribution. The incidence in male is higher than that in female, except for age from 20 to 24 years, in which the incidence is higher in female. And the reason is, this is likely to affect its most male of this year serving in military in Korea, and hepatitis A vaccination during military service has started since 2015, but this is only one immunization. Only they received this vaccination only one time. And this is clinical causes patient with fulminant hepatitis A requiring emergency liver transplantation. HAV-ALF is very rapidly progression. So they need rapid and accurate outcome prediction model for ALF with HAV. So Dr. Kim constructed a unique outcome predicting models for HAV-ALF patient. And we collaborate with him. And this alpha score system is accessible on our website. And this is Japanese trend. Trend in the number of reported cases of acute hepatitis based on infectious disease occurrence surveys in Japan. So Japanese physicians have to report to the authorities. Hepatitis A experiences outcome every 4 years in Japan until 2018. So you see that the large outbreak, so 2010, 14, and 18, but after that, there's no outbreak. This is a trend in the number of reported cases of acute liver failure due to HAV and HEV infection based on nationwide survey in Japan. So you see this 2014 and 2018 is large outbreak year of HAV. But in 2022, there's no patient, ALF patient due to HAV in Japan. This is maybe influenced by the large prevalence of COVID-19 infection. So this is a number of reported cases of hepatitis A in the infectious disease occurrence trend survey diagnosed from the 2012 to the 2018. And during this, at the outbreak of 2018, there was an increase in infections through male-to-male sexual contact, MSM. So during this outbreak, it's surprisingly, male patient is 91%. And Europride strain was detected among these patients. So this situation is very different from Korean outbreak. I think that in Korea, MSM is very strictly suppressed in the society. So Europride, you know that Europride is responsible for such outbreak of HIV. From 2011, we so in before 2011, we diagnosed acute liver failure based on the data of PT 40% or less. But after that, this INR less than more than 1.5 is included in the diagnosis criteria of ALF in Japan. And also, acute liver failure without hepatic coma, we investigated such patient also in nationwide survey. And from 2011, we also investigated patient of with ALF without hepatitis, so such as circulatory disturbances, infiltration of the liver by malignant cells, metabolic diseases, and so on. So this is the recent etiology of acute liver failure and LOHF in Japan from 2016 to 21. So in acute type, viral hepatitis is almost 27%, and among viral hepatitis, HBV is the common etiology. And this is without hepatitis patients. Among patients with without hepatitis, circulatory disturbance is common etiology in Japan. So if without hepatitis is excluded from these graphs, then among patients with hepatitis, viral hepatitis is in acute type almost 40% during these in recent years. But in old days, during these years, in acute type, viral hepatitis is almost 70%. So you see that the incidence of viral hepatitis is decreasing during these days. And this is HBV carriers registered in nationwide surveys of acute liver failure and LOHF in Japan. From 2004, ALF with HBV infection due to HBV reactivation are registered. And you see that such patient is not still exist in recent years. So this is the problem is in Japan. So the future direction of artificial liver support in acute liver failure. Traditionally, a combination of plasma exchange and hemodiafiltration, HDF, has been used. And our waking rate is almost 50%. But nowadays, we use online HDF and high flow CHDF. And this is waking rate is approximately 90% and 70%. So such artificial liver support is recommended in Japan. And such recommendation is published from the nationwide study group from Japan. So after that, Professor Inoue into talking about this in detail. So this is the causes and survival rates of acute liver failure and LOHF cases without liver transplantation. So without coma type, the outcome is very excellent, but if patient developed encephalopathy, the survival rate without liver transplantation is very miserable. So this is the survival rates of patients with acute liver failure and LOHF receiving liver transplantation from 2010 to 2021. So comparing with 2010 and 2013, this 2014 group has better prognosis. The reason of this improvement of survival rates in liver transplanted patient may be this recommended artificial liver support method, high flow CHDF and online HDF is largely introduced in many centers in Japan. So in the last part, I will talk about novel scoring system as a useful model to predict the outcome of patients with acute liver failure. This is the new scoring system created through exploratory investigation based on multivariate analysis. This study was mainly done by Dr. Naiki, Gifu University. And this system is introduced to the recommendation of deceased donor evaluation and selection in Japan. So equivalent to the highest priority status 1 with a notwithstanding that a score of 4 points or higher on scoring system is desirable. We produced outcome prediction model using data mining system. This is the decision tree algorithm for outcome prediction at onset of grade 2 or more severe hepatic encephalopathy, day 0. And we used 4 methods of data mining methods, and we produced 5 models. These decision tree model, RBF model, back propagation, discriminant type, back propagation number models, and this is the hybrid model. And this slide shows the data input screen. We need 50 items to predict the outcome of the patient, outcome of ALF patient. And this is data output screen. You can get this probability rates, day 0 and day 5, each 5 model. And this is the validation results or 4 prognosis prediction models developed by a data mining system. And you see that relatively good accuracy using this model. So this is the summary of my talk. So acute liver failure and acute liver failure in Asia, in Pacific region, in India. HEV and the was the etiology of ALF, most common causes. And in China, traditional Chinese medicine was a major causes of ALF in China. In Australia, paracetamol was the most common etiology of acute liver failure, accounting for 50% of cases. In South Korea, according to the prevalence of HAV infection, the number of HAV ALF cases requiring liver transplantation has been increasing. So acute liver failure and acute liver failure, acute hepatitis and acute liver failure in Japan. In 2018, there was an outbreak of hepatitis A between MSM. Acute liver failure due to HBV reactivation remains uneradicated, comparing approximately half of HBV carriers cases. Since 2013, with the widespread use of online HDF and high-flow CHDF, the survival rate of liver transplant cases has increased. For predicting the outcome of acute liver failure, prognosis prediction models such as scoring system or data mining models are useful in Japan. Thank you for attention.
Thank you for your detailed description about incidence and epidemiology of acute liver failure in Asia and Japan. So is there any question or comment from audience? So, thank you for, I have some questions. Okay. In Taiwan, HBV-induced acute liver failure is very rare. So HBV acute liver failure is very rare in Taiwan.
Taiwan.
So the reason is HBV global vaccine.
Maybe vaccination, but today I don't. I have no data in my presentation today. But I think vaccination is very effective.
How about Dr. Dai in Taiwan?
Of course, the first is the mass vaccination from since 1984, and the second one is we have the National Health Insurance reimbursement for NUCs for prevention of the reactivation for patients with immunosuppressant or chemotherapy. That is totally free. So with the reminding system in the hospital and everyone with chemotherapy, we can use the prevention strategy by NUCs. So almost no one will get the reactivation of HPV after chemotherapy now. Thank you.
Thank you.
Thank you. So beautiful. So any other question?
Thank you. Very nice talk. And my name is Tokushige from Japan. And I have one question. The cause of, in Japan, cause of ACLF were infection or alcohol intake, right? But these factors were contraindication liver transplantation. How many percent of ACLF received liver transplantation in Japan?
Thank you.
Case?
Thank you very much. Liver damage due to alcoholism is excluded from the Japanese the diagnosis criteria for ACLF. So maybe a alcoholic acute liver disturbance is not included in the national survey. So I cannot answer to your question, but some patient with ACLF receives ACLF due to alcohol abuse receive liver transplantation, but not so many patients. Very limited. I think very limited in Japan.
Okay, thank you.
And, please.
Okay, Nakayama sensei, I just want to know the condition for anti-HIV vaccination condition in Japan. The vaccination.
Vaccination.
Yeah.
Vaccination for baby and small children started 2014 or 15 in Japan, but very recent years. So very late response in Japan. You know that in several days, several years.
The recent years.
Recent years.
Okay. So for the adults, do you recommend to get the vaccination in your Japanese patients?
Yes, of
Okay.
course.
Finally, and one question, in Asia, indeterminate causes is larger. So, including with autoimmune.
Yes, maybe I think, but in US, in US, some publication that they try to find the real reason among this indeterminate etiology. So in Asia group, maybe so autoimmune hepatitis is included in these patients.
So we have to decide the criteria of autoimmune hepatitis induced ALF.
Yes. Maybe this depends on the data of nationwide survey. Maybe I suppose that many deficient data is a reason of the increase of indeterminate etiology.
Thank you.
I have a question about the scoring system. What is the generalizability of this scoring system? And could I apply the other country only in Japan?
Yes.
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 The system.
We have no data for the foreign countries, but maybe hepatitis, etiology with hepatitis, viral hepatitis, autoimmune drug induced hepatitis, maybe effective for such population. But hepatitis, without hepatitis patient, we have no data.
Okay, thank you.
Thank you very much, Dr. Nakayama.
Okay. Next speaker is Dr. Kazuaki Inoue from Tokyo, Japan, and he is the specialty to the HDF. So please start.
Well, thank you, Chairperson Asahina. I'm deeply grateful to the opportunity to discuss my life work on artificial liver support. Allow me introduce myself. I'm Kazaki Inoue from IUHW Narita Hospital. That hospital located in Chiba Prefecture, not Tokyo. And with approximately 5,000 sessions of artificial liver support experience, I'm very honored to share my insight and experience with you today. Liver transplantation has a notably improved survival rate of patients with acute liver failure. However, the efficacy of artificial liver support device in enhancing patient survival remains very limited. The primary goal of artificial liver support is to sustain patients with acute liver failure or acute on chronic liver failure until their liver can regenerate and regain functionality. In cases where liver regeneration is not feasible or is progressively deteriorating, ALS serve as a critical intervention until transplantation becomes viable. It's important to note that while ALS can restore consciousness, its correlation with overall patient survival is not always straightforward. I'd like to highlight two key clinical questions regarding artificial liver support system. What constitutes an appropriate clinical endpoint for evaluating ALS efficacy? While surviving rate is commonly used in clinical studies, given that ALS is primarily symptomatic treatment, I argue that consciousness recovery may be a more suitable measure. What substance contributes to hepatic encephalopathy? Identifying the responsible substance is crucial for improving ALS efficacy. Despite my historical challenges, ALS continues to evolve based on our clinical experience. This slide provides an overview of developmental milestones in artificial liver support. Throughout today's presentation, I will elaborate on several key methods that have marked significant advantage this field. And please note, Operon's work has introduced as HDF, but Operon's paper describes his method as hemodialysis. In his days, the device for hemodialysis did not optimize for high-performance membrane. Therefore, his hemodialysis requires large volume of fluid supplementation. Therefore, I introduced his work, hemodiafiltration. Hemodialysis primarily targets the removal of molecules smaller than 5,000 Dalton, such as ammonia, and additionally, it can eliminate GABA or short-chain fatty acid or some amino acid. Despite its broad spectrum of removal, hemodialysis was found to be ineffective on treating hepatic encephalopathy in cases acute liver failure. Considering the experience from that era is very, very crucial when contemplating the molecular weight of substances that contribute to hepatic coma, especially today's dialysis membrane have the capability to remove middle molecular weight substance as well, especially in Japan. Whole blood exchange transfusion, a procedure involving the replacement of approximately 6 liters of patient blood with normal donor blood, was introduced in 1958 and remained in use until the 1970s. However, its efficacy was called into question following the small-scale randomized control study in 1973. As a result, WBET is currently employed only specific cases of acute liver failure, primarily in pediatric region. The plasma exchange, this is has a big problem. The beneficial effect of plasma exchange for the treatment of fulminant hepatic failure was initially reported in 1967. PE was noted to be particularly effective in correcting coagulation abnormality and improving encephalopathy associated with acute liver failure. Furthermore, significant improvement in survival rate were observed in various case series following the introduction of PE. In our own experience with plasma exchange for the treatment of fulminant hepatic failure, we achieved an overall survival rate approximately 30%, while PE proved effective in replenishing depleted plasma component. Its efficacy in removing substance with large body volume, large body pool was very, very limited. Additionally, we observed they have very little effect on hepatic encephalopathy. Since 1950s, efforts have been underway to eliminate toxic substance from the blood patient with acute liver failure throughout perfusion with various adsorbents. Subsequently, resin-based hemoperfusion was introduced capable of adsorbing bilirubin and bile acid. However, the clinical application of resin hemoperfusion yield unsatisfactory result and exhibit low biocompatibility. And in 1974, a group at King's College reported favorable clinical effect of hemoperfusion using 160 grams of coated activated charcoal. Around the same time, Japanese group conducted plasma perfusion using uncoated charcoal. However, this method yielded very low survival rate, 90.2. That was less than control group. This treatment could not remove small molecular substance. Therefore, that in patients under the treatment of charcoal frequently caused brain edema. And subsequently, the group of King's College evaluated the efficacy of the charcoal hemoperfusion method in a randomized controlled trial and found no significant beneficial effect. And I describe here the Japan way. The term Japan way gained prominence thanks to the Japan Rugby Union head coach Eddie Jones. Drawing from our clinical experience, Japanese investigators have actively developed innovative method. Here, I'll provide a clinical background for the Japan way. Intensive medical care remains the cornerstone of treatment of acute liver failure, giving the limited availability of liver transplant primarily from living donor. Artificial liver support serve as a crucial intervention in acute liver failure management. It acts as a reliable bridge to successful liver transplant, sustaining a patient for approximately 2 weeks to 4 weeks without any complication. It aims to reduce the number of candidates for liver transplantation by promoting a recovery without need of liver transplant. Artificial liver support stands as one of the 3 principal treatments for ALF. This slide highlights two major symptoms of acute liver failure: bleeding tendency and hepatic coma. And brain edema, in particular, pose a fatal complication if the efficacy of artificial liver support is inadequate. One plausible mechanism contributing brain edema is ammonia glutamine hypothesis. I describe this hypothesis by later. Managing these symptoms is a crucial theme for ALS. Effective strategies for addressing bleeding tendency and hepatic comas are essential to improving patient outcome and reducing mortality associated with ALF. And the presentation of Japan way aimed to demonstrate the development of a reliable artificial liver support system, specifically plasma exchange in combination with hemodiafiltration using high-performance membrane and using high volume of buffer. We emphasize the clinical effect and efficacy of this approach, particularly in significant capacity for removing glutamine. Glutamine is believed to be a key substance responsible for brain edema and has a large distribution volume in our body. HDF remove glutamine not only from our bloodstream, but also intracellular space. By effectively removing glutamine, our artificial liver support system demonstrate promising result in managing hepatic coma and preventing fatal complications such as brain edema. And this slide summarizes the advantage and disadvantage of plasma exchange. In summary, primary disadvantage of plasma exchange is its inability to sufficiently remove water-soluble substance, especially water-soluble substance with large body volume, resulting in a poor recovery from hepatic coma, which is a very, very significant concern. And hemodialysis has proven ineffective against hepatic coma. A common observation in our clinical experience, identifying the responsive factor for hepatic coma is crucial and serves as a clinical turning point in the development of artificial liver support. One approach, assuming protein binding toxin as a responsible factor and led to development molecular adsorbent recirculating system that is called Mars or Prometheus. On the other hand, Japan way hypothesized water-soluble toxin as responsible for factors and has consequently developed plasma exchange in combination with hemodiafiltration using high-performance membrane and huge volume of buffer. And this milestone paper introduced the combination of plasma exchange with hemodiafiltration, serving as a prototype of artificial liver support. In this study, patients who had fallen into grade 5 hepatic coma regained consciousness after undergoing several sessions of ALS. The focus was on achieving safe and efficient removal of toxic middle molecular and lower weight molecular substance using high performance membrane. In this case, these investigators use a PMMM membrane. This innovative approach aims to address the clinical need for the effective detoxification in patients with acute liver failure. And we have the significant improvement of acute liver failure support system as a development of chemical fiber development. First generation was PMMA and second generation cellulose triacetate. Now we use polysulfone membrane that may allow us to use huge volume of buffer. Therefore, we can use 300 to 500 liter of buffer. This circuit diagram illustrates the setup for online hemodiafiltration, where we utilize the pre-dilution mode to infuse substitution fluid. The total amount of buffer usually ranges 200 to 500 liter per one session. Advantage of this method might include its simplicity and feasibility and high efficacy, but it requires a central ultra-pure water supply system. This slide illustrates the effect of plasma exchange in combination with hemodiafiltration on hepatic coma. In previous presentation by Dr. Nakayama reported in Japanese HDF effect, about 90% patient regain their consciousness. And what is the ideal artificial liver support? Ideal artificial liver support is one can sustain patient live during the period the most severe liver failure, comparable to a hepatic state. In other words, it should effectively mimic the vital function of the liver, allowing patients to survive, potentially recover from acute liver failure until liver transplant become feasible or until liver function can be restored. Sorry. According to the report by Albright in Hepatology 2006, there is a general scheme by which ammonia and glutamine lead to mitochondrial failure, resulting in astrocyte dysfunction and clinical development of brain edema. If you have the interest in this paper, please, I recommend you this paper read precisely. And this case is this slide depicts the clinical cause of subacute type acute liver failure. The patient experienced the onset of first symptom approximately 1 month before admission. Upon referral to our hospital, the patient was in state of deep coma. Imaging by a CT scan revealed liver with a volume shrinked at 500 to 14 milliliter, and evidence of brain edema was also observed. Following initiation of artificial liver support system, the patient gradually regained consciousness. However, despite the improvement in neurological state, liver regeneration did not occur. And this slide demonstrates a change in plasma glutamine level before and after artificial liver support system. Hemodialysis filtration is highly effective to removing glutamine, a substance with a large volume of distribution. Conversely, plasma exchange alone hardly alters the plasma glutamine level. And the effect of plasma exchange is very short term. This emphasizes the superior efficacy of HDF removing glutamine compared to PE alone, highlighting the importance of in combination different modalities in ARS treatment to optimize patient outcome. This slide presents summarized data regarding glutamine removal during artificial liver support treatment. We collect dialyzed fluid every 10 minutes. Therefore, it is very labor intensive study, and this data is integral data of total glutamine removal. The first column indicates the total amount of glutamine removed, while the second column represents the total volume of buffer, and the third column indicates the equivalent plasma volume of glutamine, calculated as the removed glutamine divided by the plasma glutamine concentration before artificial liver support system. To determine which combination shows a significant correlation, we need to analyze the relation between total glutamine removal and the equivalent plasma volume of glutamine across the different volume buffer. Answer will be provided on the next slide. The analysis revealed significant correlation between total buffer volume and equivalent plasma volume of removed glutamine. This suggests to effectively remove substance with a large body volume, such as glutamine, blood purification using a large volume of buffer is necessary. This finding indicates that repeated artificial liver support may be required to effectively to toxic substance with large body volume. This slide indicates the detoxification power of hemodiafiltration in this case. The last slide is in the case of a patient with hyperacute liver failure due to acute infection hepatitis B virus. Upon admission, the patient was state of deep coma with elevated level of ammonia exceeding 800 and AST over 10,000. However, through the repeated session of artificial liver support, the patient regained consciousness. This case underscores the effectiveness of ALS in managing Masav's case of acute liver failure, even in hyperacute failure, such as hepatitis B virus infection induced acute liver failure. On day 8 and day 12, cortical electrical encephalograph recording showed a flat pattern, indicating severe neurological dysfunction. However, through the repeated artificial liver support treatment, the patient emerged from deep coma accompanied by decrease in plasma glutamine level. Despite this improvement in neurological status, the patient remained in a hepatic state while awaiting the organ donor for liver transplant. This case highlights the potential errors in reversing coma associated with acute liver failure, although it cannot address the underlying hepatic dysfunction necessitating liver transplant. Conclusion. Plasma exchange in combination with online hemodiafiltration utilizing a large volume buffer and high-performance membrane represent a promising method in the treatment of acute liver failure. This approach effectively removes toxic substance across a large of molecular weight from low to middle molecular weight by employing a substance volume buffer. By utilizing huge buffer volume, the treatment optimizes the removal of harmful substance, therefore potentially improving patient outcome in cases of acute liver failure. Thank you for your attention.
Thank you, Dr. Inoue. And now this paper is open to discussion. Any comment or questions? Okay, please.
A nice presentation. I'm a postdoctor from China. I'm also interested in the artificial organ support system. First, my first question is what is the instance of the ALF in Japan? And the second question is, as you mentioned just in the PPT, I noticed that also very small patients will receive the liver transplantation. So how is the ALS used in the clinical practice in Japan? Thank you.
Sorry, please repeat your first question.
The first question, what is the incidence of the acute liver failure in Japan?
Incidence?
Yes.
Incidence of acute liver failures is about 1%. Professor Nakayama, 1% of acute hepatitis. About now about 100 to 200 cases per year.
Oh, thank you. And as the liver transplantation I mentioned, you just mentioned about that small patient receive the liver transplantation. So how is the artificial liver support system used in the clinical practice in Japan? Is it very common?
Artificial liver support is very common in Japan. Mainly used in Japan, the intensive medical care is mainstay treatment for acute liver failure. Liver transplant is very limited number, especially brain-death donor is around 100 per year. It is more less than in the number in China. Therefore, we use artificial liver support in the treatment of intensive medical care, and in some cases, we use this treatment to bridge the patient to our liver transplant. Okay.
Okay, thank you.
Thank you. Any other question, please?
Thank you for your very beautiful presentation. I'm also from China, so we have a lot of liver failure patients. In my experience, I think artificial liver support system is very important for liver failure, but in which time you do it is very important. In my opinion, if two lights liver failure, such as deep coma or the new PTA or RNA is very high, artificial support system cannot work so well. So in China, we are often divided the liver failure into 3 or more stages, including pre-liver failure stage, early liver failure stage, and light liver failure stage. In my opinion, the very light liver failure stage, we almost need liver transplantation. Artificial liver support system works very limited. So I don't know how about your opinion at which time is the best time for liver support system. Thank you.
Thank you. Very valuable opinion about the treatment of acute liver failure. I also think the prevention of the development of acute liver failure is very important in the stage of acute severe hepatitis. And we usually predict the risk of the development of acute liver failure in the stage of acute severe hepatitis. And in our system is feasible in Japan, but it requires a very pure water system. But it is very difficult in other Asian countries. Therefore, I recommend in the participant of Asian country to predict the development, the risk of development of acute liver failure in the stage of acute severe hepatitis. Thank you very much.
Thank you. We often use in China, mostly in most hospital, we often use half plasma, almost Europe, the premier plasma exchange need more than 2,000 plasma. But nowadays we just use half plasma, about 1,000 plasma, and the combination with DP mass. That's very often in China. So we think that that's maybe we in Guangzhou experts published some paper about this, and recently maybe another experts from Guangzhou will report their RCT research about this work. They almost see this style of artificial support system is work, and the main point is when you do it. Thank you.
Thank you. I think my mouse system is a compromising system to remove protein binding toxin and water soluble toxin. Therefore, I recommend many investigators to use the hemodiafiltration. It is very easy and feasible in Japan. And if you construct the pure water supplying system, it is very easy and effective system. MAS is a complicated system. It uses albumin to use absorbent, but it is, I think, not effective. Several times I discussed investigator, Dr. Stange. He also recognized the less effective of MAS. Thank you.
Thank you. Thank you. Okay, Dr. Inoue, it's time to close to this session. Thank you, Dr. Inoue. So I have to close this interesting session. I express sincere appreciation from the three distinguished speakers, Dr. Nakamoto and Dr. Nakayama and Dr. Inoue, and the audiences, and to create an active discussion. Thank you very much.
Thank you very much, the moderators and lecturers.